So you may ask, with all that stuff about neuroplasticity learning is all super interesting, but what does that have to do with physical therapy? So, well, it has a lot to do with it, actually. We're going to talk about cellular recovery from injury. So, injuries that damage or sever axons, particularly in the peripheral nervous system, cause degeneration, but they may not result in cell death. When a neuron dies, the nervous system promotes recovery by altering specific synapses in other neurons. So some neurons can regenerate their axons by sprouting a new axon. The myelin sheath has a big role to play in this, in guiding the axons for how they're going to heal. So if the injury doesn't result in cell death, then the cell could sprout another axon. If the injury to the axon or an injury that destroys the cell body could lead to the death of the cell, and then you're not going to have any sprouting. So there are two different types of sprouting. One of them is collateral sprouting, where basically an axon sprouts another axon to replace the one that was damaged, or regenerative sprouting, where a new axon takes the place of the one that was damaged. So basically in the peripheral nervous system, you can sprout new axons. The destruction of a cell body usually causes cell death, but again, you can have functional recovery if another cell takes over the actions of that cell. So when the axon is injured, the myelin sheath breaks down, the cell body changes, postsynaptic cells degenerate, and glial cells clean up the debris. So if the postsynaptic cell is a muscle fiber, that's where you get muscle fiber atrophy with a nerve injury. The damage to an axon evolves hours and days following the injury due to a cascade of cellular events. So the extent of the deficit that remains after an injury depends on the degree of damage to the myelin tracts, or the white fiber tracts in the spinal cord, and the vertebral level of the injury. So if there's still if the tracts are still intact, you can actually have that collateral sprouting. If the cell body itself dies, then you got to replace it with another cell. In the periphery, you often get axon severance when injuries occur in the peripheral nervous system. So they might be severed from sharp objects or from extreme stretch that pulls the axon apart. The sharp object that severs it might be a surgeon's scalpel if you're having surgery. If you've ever had surgery and you have numbness on one side of the incision, it's because axons were severed. Those axons can grow back. So the growth of a new branch of an intact axon, or the regrowth of a damaged axon, is called sprouting. So you can have that collateral sprouting, where the denervated target attracts side sprouts from nearby undamaged axons, or regenerative sprouting, where the uninjured axon issues side sprouts to form new synapses with undamaged neurons. So the axon regrows at a rate of about 1 millimeter per day. So you can see it's not a quick regrowth, but there is the possibility for regrowth in the peripheral nervous system, which is great. You can actually recover from those over time. So that's the real trick, is if you can think of it as about 1 millimeter a day, or approximately 1 inch per month. So that's something that I frequently tell my patients. After surgery, they say, oh, it's really numb over here. Is that going to get any better? And I say, yeah, but it's going to get better 1 millimeter at a time. 1 millimeter a day. You do the math and see when it comes back. So it depends on the extent of the damage, the extent of the surgery, and how long it's going to take, and the length of the axon, how long it's going to take to grow back. In the central nervous system lesions can often be irreversible due to lack of nerve growth factor, among other factors. So functional axon regeneration does not occur in central nervous system axons like it does in peripheral nervous system axons. There is a growth inhibitor that's called neurite growth inhibitor, and its nickname is NOGO. And it is expressed in oligodendrocytes, and it halts central nervous system axon recovery. So that's a line of current research to block NOGO to aid in central nervous system recovery. Glial scarring can also prevent regeneration. Stem cells may eventually provide another method of treating white matter injuries such as spinal cord injuries and demyelinating diseases such as MS, but there's not a current stem cell treatment in place that can do that. So the fact that there's no nerve growth factor, we actually have NOGO, which is an outgrowth inhibitor, and glial scarring. Those are the three factors that prevent recovery of axonal injury in the central nervous system. So those you should know. So following a central nervous system injury, the body uses several mechanisms to overcome the damage. We know we're not going to regenerate axons, so there has to be something that has to happen. A lot of the same mechanisms that are responsible for brain plasticity during learning are involved in the recovery period following neuronal injury. So synaptic mechanisms for recovery include the recovery of synaptic effectiveness, which the example here is you have edema after an injury. Reduction of the edema returns the synapse back to normal activity. So that's nice. The edema is blocking the nerve transmission. The edema goes down or goes away, and you have nerve transmission again. Denervation hypersensitivity is the formation of new receptors. It creates increased neurotransmitter receptor activity. So that's what we were talking about, that hypersensitivity after an injury. You have the body's trying to recover, and you have increased neurotransmitter and receptor activity as part of that recovery. Synaptic hypereffectiveness is where neurotransmitter accumulates in an undamaged axon terminal, which results in increased neurotransmitter release. So again, we're trying to recover that function in the area. And the other recovery mechanism is the unmasking of silent synapses. So silent or unused synapses are disinhibited due to the injury and the need for new connections and pathways. So the existing pathways were damaged, and now we need new ones to take their place. The other recovery from a stroke that can happen, or from any central nervous system injury, is functional reorganization of the cerebral cortex, which is where an area of the cerebral cortex that wasn't previously being used for a particular function gets pulled in to reorganize and do that function now that there's a damaged area. So researchers can map functional areas of the cerebral cortex by recording neuron activity in response to sensory stimulation or active muscle contractions. So the cortical areas adapt to changes in sensory input, experience, learning, and brain injury. Cortical plasticity and reorganization are considered to be the likely mechanisms that drive functional activity after a stroke, but reorganization can take years. So they used to say, and you'll still hear this out there sometimes, they'll say, oh, well, you can only recover for the first 3 months after your stroke, or 6 months, or they'll give a number, and then after that you're not going to recover any more function. And that isn't true. You can actually have reorganization and function that recovers years after the original injury. So even though when you're working with someone with a stroke, I often tell people, they say, well, when am I going to get back to normal? And I tell them, you're going to have to get used to your new normal. They're never going to get back to exactly where they were, but they can recover function if they keep working on it. So repeated stimulation of somatosensory pathways can cause increases in inhibitory neurotransmitters, decreasing the sensory cortex response to overstimulation. Understimulation can have the opposite effect, causing the cortex to be more responsive to weak sensory inputs. So the changes in neurotransmitter release are related to the activity that's going on in the pathway. When you have a brain injury, neurons die and they don't regenerate. There is a process, it's a cascade of chemical events that's called excitotoxicity. And it's overexcitation of a neuron leading to cell death. So oxygen-deprived cells, and a lot of times this happens in an ischemic stroke, cells that are deprived of oxygen release excess glutamate that produce a cascade of cell death. So you have ischemia in this chart. The cells release excess glutamate. The glutamate activates calcium channels and release of internal calcium stores, which result in 3 different processes: increased glycolysis, which results in excess lactic acid, which results in cell injury and death, or increased intracellular water, which increases cell swelling, which results in cell injury and death, and activated protein enzymes, which results in more oxygen-free radicals, which results in cell injury and death. So all of these processes result from excitotoxicity, but they all produce that cascade of cell death. So even the original cells that died, that released the glutamate, kill ones around it, so it can affect a larger area in the brain. Stem cells are often involved in brain remodeling following a neurological injury. The neural precursor cells migrate toward the ischemic area after a stroke, but unfortunately, a lot of the cells that arrive near the ischemic area don't survive. The theory is that it's because of inflammation or because of the excitotoxicity in the area. Those cells get sucked into the cell death cascade as well. So there are efforts for treatments to decrease inflammation in the area, decrease that cascade of glutamate, and see if they can save as many cells as possible. So the focus on CVA treatment is early intervention, early treatment to have the least amount of damage possible. So if you ever suspect that somebody is having a stroke, get them into the hospital right away. And get them some treatment so they can lose as little as possible and have a better recovery. So rehabilitation has effects on plasticity as well. The intensity and timing of rehab influences recovery. So because of that, the reorganization of the undamaged regions, we need to do functional task-oriented training that's not too intense early on, and that can help guide that reorganization of the undamaged regions. There's often a loss of function in adjacent undamaged regions of the brain, which may occur with inactivity. So you don't want to work too hard and you don't want to work too easy. But it's important to start rehabilitation early in a task-oriented and not too intense way so you don't lose function in undamaged region of the brain. So there are specific types of rehabilitation that are effective during the chronic phase of post-stroke. So there are some things that you can do later on, not in the acute phase, but in the chronic phase, that can really be helpful, but excessively vigorous rehabilitation of motor function too soon after the injury can be counterproductive. So the early onset of rehab is most beneficial if it's task-oriented and not too intense. Intense activity in the acute phase could cause more excitotoxicity. So in the study that's quoted in the book, which was rehab 5 or 30 days post-injury, 5 days shows the greatest increase in function. So you need to start rehabilitation early. If you work in an acute care setting, you'll be working with people in the acute phase of stroke rehabilitation. And it's really interesting. I mean, you can actually do a lot with people depending on what their effects were. But a lot of times what you're doing, depending on where you work, of course, but a lot of times in the acute care setting, you're assessing the person at each therapy opportunity, and you're trying to see what is their endurance like, what is their capacity, would they be able to do intense inpatient rehab. The people who can do that often have a better recovery than people who can't tolerate that level of activity. So task-specific training produces long-lasting cortical reorganization of the brain areas activated. So you want to have people doing functional activities. Task-specific training induces more regular patterns of brain activation compared with general use training of the upper extremity in individuals with stroke. So rather than doing strengthening or range of motion or something with an upper extremity, you actually want to have them doing something with the affected upper extremity. Some types of rehabilitation are beneficial even if they're initiated during the chronic stage of post-stroke, because plasticity can occur with rehabilitation after months or years following neurologic injury. I've worked with people who were 15 years post-CVA and still making gains. So you can definitely, the gains are going to be slower and they're going to take longer and they're going to be harder. But you can still make gains during the chronic stage post-stroke, because you still have the ability to cause neuroplastic changes in the unaffected regions of the brain.